Hi, good morning. It's me, Dr. Mohammed Kazafi, and you are watching Dr. Mohammed Kazafi Views. And I am starting one very good topic, very common topic, and every neurosurgeon must know about it. And in my humble opinion, it's a very effective and very important topic to know. So, the 30-year-old male present one day after lifting a heavy box at home that led a excruciating left leg pain, foot drop, perianal tingling, and inability to void for the past 12 hours. Positive exam finding include weak left knee extension 3 over 5, left ankle dorsiflexion 2 over 5, and the left plantar flexion 4 over 5. And the left extensor hallucis longus power is 1 over 5, and he has sensory loss to pinprick in the perianal region and loss of ankle reflex bilaterally and a post void residual of 450 ml. So my definitely provisional diagnosis was Cauda equina syndrome. But the differential diagnosis here, like the disc herniation, extrusion with the Cauda equina compression, pathological compression fracture, spinal stenosis, discitis, osteomyelitis, epidural abscess, intradural tumor with acute intratumoral hemorrhage, epidural hematoma. So, the clinical presentation to distinct clinical types of the Cauda equina syndrome has been described acute and insidious. So, the acute Cauda equina syndrome is characterized by sudden onset of the severe low back pain, sciatica, urinary retention, motor weakness of the lower extremities, and the perianal anesthesia, typically the result of the acute central disc herniation. Insidious Cauda equina syndrome is characterized by the recurrent episode of the low back pain occurring over week to year and with the gradual onset of the sciatica, sensory motor loss, and the bowel and the bladder dysfunction typically occur in the setting of the long-standing spinal stenosis. Genitourinary dysfunction is a hallmark element in the Cauda equina syndrome. Early bladder dysfunction can be subtle and involving difficulty initiating the urinary stream, which may progress to the urinary retention and eventually overflow incontinence. Dense sensory loss involving the perineum, buttock, and the posteromedial thigh, which with the saddle anesthesia is a relatively late sign of the Cauda equina syndrome and may indicate limited potential for recovery to normal bladder function. For further workup, the importance of the thorough clinical examination remain paramount to quickly detecting Cauda equina syndrome, as prolonged delay in diagnosis and treatment can lead to irreversible consequences. So the Cauda equina syndrome patient typically have preserved sensation to pressure and the light touch. So if discrimination is not made between the pinprick and the light touch sensation, then the diagnosis can be missed and sensation to the pinprick in the perianal region. So the S2, S4 dermatome, perineum and the posterior thigh must be assessed. Decreased rectal tone is often an early finding in patients with the Cauda equina syndrome. A rectal examination must be performed on all patients with potential Cauda equina syndrome to assess the tone and the voluntary contracture of the external anal sphincter. Both the anal wing test and the bulbocavernous reflex must be evaluated, and the measurement of the post-void residual volume provide an accurate assessment of the urinary retention. X-rays, including flexion extension views, should be quickly obtained to rule out instability for the pre-op planning, and if instability is present, fusion must be considered. CBC chemistry coagulation performed pre-op urgent surgery warranted. Pathophysiologically, the lack of the epi and the lack of the mechanical compression further impair the nutrition of the neural tissue by reducing both neural blood flow and diffusion from the surrounding CSF. Ischemic injury from severe compression is an already hypovascular region and heightens the predisposition of the Cauda equina to compression. The compression of the Cauda equina may be compared to the compartment syndrome, whether intraneural edema caused by the compression induce a cycle of reducing perfusion to the nerve, and which in turn begins further edema. So here the CSF is a surgical emergency and warrant early decompression of the nerve root to prevent progression of neurological deficit, to maximize potential for recovery. Traditional practice involving surgical decompression, preferably within 24 hours. A meta-analysis found a statistical significant improvement in radiologically and neurological outcome of the patient where operated within 48 hours of the onset of the symptom, and intraoperative imaging is performed to confirm the surgical level by placing a radio-opaque instrument on the spinous process at the level of interest. Here, if you appreciate this, if this kind of a disc in the axial you can appreciate, and in the sagittal, so you can notice how much pressure is this, and it must be treated surgically immediately, and it is very important to treat. Subperiosteal muscle dissection is performed to spinolaminar line, with the lateral dissection proceeding to the medial edge of the facet complex. A wide laminoplasty is performed with the high-speed drill and followed by careful removal of the underlying ligament, often tented dorsally due to the ventral mass compression. Once the dorsal compression is complete, the thecal sac is gently reflected medially to perform a discectomy, and if ventral compression secondary to the disc herniation is the etiological source. If hypertrophied facet or the lateral ligament significantly contribute to the canal narrowing, and the partial facetectomies may be required. In most cases, a 50% facetectomy on one side or the 25% facetectomy bilaterally can be accomplished without need for the stabilization or fusion. Few points are complication and avoidance management here, such as if there is a complication, the persistent bowel and the bladder dysfunction, we can avoid by early intervention with the decompression of the Cauda equina, increase the chance of regaining bladder control less than 48 hours. And if there is a recurrence persistence of the symptom, then inadequate removal of the bony, nuclear and the ligamentous and a compressive element may allow persistent symptomatology. Here, I want to present in front of you one thing it is very important regarding the complication. For example, if there is a complication is a CSF leak, so then the severity of the compression of the dural sac with the tenting of the dura above and below the level of the compression and predisposing to the durotomy, and when such occur, it is crucial to locate the dural injury and close the defect in a watertight fashion is important, and this can be performed with the neurolon suture, and when necessary a muscle graft and the dural sealant is important. In this case of the ventral defect, or if the defect cannot be closed primarily, is thought to be layered musculofacial closure is paramount in preventing the external leakage, and in such instance a lumbar drain may be placed to shunt CSF at the level of the back for the L4-5 days. I'm sorry, at the level of the back for 4 to 5 days. So this is the little bit about the Cauda equina. I want to tell you one thing here. Few things I want to repeat here, or I must want to explain in front of you regarding the Cauda equina syndrome. Actually, the collection of nerve at the end of the spinal cord is known as the Cauda equina. So due to its resemblance to the horse tail, the spinal cord ends at the upper portion of the lumbar lower back spine, and the individual nerve root at the end of the spinal cord that provides motor and the sensory function to the legs and the bladder continue along in the spinal canal. The Cauda equina is the continuation of these nerve roots in the lumbar and the sacral region, and these nerves sends and receive message to and from the lower limbs and the pelvic organ. Cauda equina syndrome occurs when there is a dysfunction of the multiple lumbar and the sacral nerve root of Cauda equina. Cauda equina syndrome most commonly results from the massive disc herniation in the lumbar region, and the single excessive strain or injury may cause a herniated disc. However, many disc herniation do not necessarily have an identified cause, and the size of the disc herniation that results in the Cauda equina is often much larger than the normal. However, spinal canal is smaller due to the conditions such as the arthritis. A smaller disc herniation can produce Cauda equina syndrome. Potential cause of the Cauda equina syndrome such as the spinal lesion and tumor, spinal infection or inflammation, lumbar spinal stenosis, violent injuries to the lower back, gunshot, falls, auto accidents, birth abnormalities, spinal arteriovenous malformation, spinal hemorrhage, subarachnoid, subdural, epidural, or the post-operative lumbar spine surgery complication and spinal anesthesia. So these are the potential causes of the Cauda equina syndrome, and I presented in front of you. Regarding the symptoms and the diagnosis, Cauda equina syndrome is accompanied by by the range of symptoms and the severity of which depend upon the degree of the compression and the precise nerve root that are being compressed. Patient with the Cauda equina syndrome may experience some or all of these red flag symptoms, and the urinary retention, the most common symptom. The patient's bladder filled with urine, but the patient does not experience the normal sensation or urge to urinate. Urinary and a fecal incontinence, the overall bladder can result in incontinence of urine. Incontinence of stool can occur due to the dysfunction of the anal sphincters. Subtle anesthesia, sensory disturbance, which can involve the anus, genitalia, and the buttock region. weakness or the paralysis of usually more than one nerve root, and the weakness can affect lower extremity and pain in the back or the leg, also known as sciatica, sexual dysfunction. If the patient is experiencing any of the red flags, a symptom above, immediately medical attention is required to evaluate whether these symptoms represent Cauda equina syndrome or not. But the weakness or paralysis of usually more than one nerve root, this is really a major urinary retention which we cannot avoid. Definitely urinary and the fecal incontinence we cannot avoid, saddle anesthesia we cannot avoid, weakness or the paralysis more than one nerve root. I am just repeating that because it's a very sexual dysfunction, and pain in back or leg is also important, and the testing and the diagnosis. So besides a herniated disc, other condition with symptoms that can similar to the Cauda equina syndrome include the peripheral nerve disorder, conus medullaris syndrome, spinal cord compression or irritation or compression of the nerve after they exit the spinal column and travel through the pelvis, a condition known as lumbosacral plexopathy. So the test that may be helpful in diagnosing Cauda equina syndrome. Patient history and the physical exam extremely important to assess the Cauda equina syndrome, and magnetic resonance imaging, a diagnostic test that produce three-dimensional image of the body structure. Using magnetic field and the computer technology, MRI produce images of the spinal cord, nerve root, and surrounding area. CT scan and X-ray of the spinal canal that give the good definition of the bone, and if the Cauda equina syndrome is secondary to the bone collapse from the trauma or cancer, then this study can help defining that. So the visualization of the disc are not as easily seen on CT scan, but if no MRI is available, the study can give information helpful to evaluate the anatomy of the region, and particularly if done in the combination with the myelogram described below. Myelogram, X-ray of the spinal canal following injection of the contrast material into the surrounding cerebrospinal fluid, spaces and can show displacement on the spinal cord and the spinal nerve due to the herniated disc, and the bone spur, tumor, etc. are there. Treatment I already explained for my patient, but I want to explain a little more here. Once the diagnosis of the Cauda equina syndrome is made and the etiology established, and the urgent emergent surgery is usually the treatment of the choice, and the goal is to free up the compressed nerve root and give them a best chance of the recovery possible if untreated. So the Cauda equina syndrome can result in the permanent paralysis and incontinence, so that those experience any of the red flag syndrome symptoms should be evaluated by a neurosurgeon and orthopedic spine surgeon as soon as possible. Prompt surgery is the best treatment for the patient with the Cauda equina syndrome. So treating patient with 48 hours after the onset of the syndrome provide a significant advantage in improving sensory and motor deficit as well as urinary and rectal function. And even patient who undergo surgery after a 48-hour ideal time frame may experience improvement. Although short-term recovery of the bladder function may lag behind reversal of the lower extremity motor deficit, and the function may continue to improve years after the surgery, and the following surgery and drug therapy coupled with the intermittent self-catheterization can help lead to slow but steady recovery of bladder and the bowel function. Follow-up with the patient surgeon occur a few weeks after surgery to check healing and the progress, and many of these patients also require long-term follow-up with rehabilitation medicine. Cauda equina is relatively rare condition, and therefore data on long-term outcome is limited. Cauda equina syndrome can affect people both physically and emotionally, particularly if it is chronic, and patient with the Cauda equina syndrome may no longer to be able to work either because of the severe pain, socially unacceptable incontinent problem, motor weakness, and the sensory loss, or a combination of these symptoms. Loss of bladder and the bowel control can be extremely distressing and have a high negative impact on the social life, work, and the relationship. Patient with the Cauda equina syndrome may develop frequent urinary infection. Sexual dysfunction can be devastating to the patient and his and her partner and may lead to relationship difficulties and depression. Severe nerve type neurogenic pain may require prescription pain medication with the side effect that may cause further problem, and if the pain is chronic, it may become centralized and radiate to the other area of the body. Neurogenic pain tends to be worse at the night and may interfere with the sleep. This type of a pain tends to produce a burning feeling that can become constant and unbearable, so the sensory loss may range from a pins and needles to complete numbness and may affect the bladder, bowel, and the genital area, and weakness is usually in the legs and may contribute to the problem walking. It is essential that the patient with the Cauda equina syndrome receive emotional support from a network of the friends and the family member, and if possible, it is important to work closely with your physician on medication and the pain management. There are several medications prescribed to address the pain, bladder, and the bowel problem. In addition, some patients find that the physical therapy and the psychological counseling help them cope with the Cauda equina syndrome. So this is, I think, good enough regarding the Cauda equina syndrome, and I hope you will like it. If you like it, please subscribe me, share, and support us. Thank you so much. See you one more with another topic. Thank you.